All right, well, I'm going to work off my slides because that's how I have organized my presentation. I'm going to begin with, I'm here representing Healthcare for All Minnesota. I've got two of my fellow travelers here today, Monica. I think we told everybody we're taping, but I think it's focused mainly on me. HCAMN, Healthcare for All Minnesota, was founded in 2015. Our purpose is to enact universal coverage under a single-payer system. A single-payer system gets its name from the fact that under such a system, only one payer reimburses doctors and hospitals and other providers. Provider basically means anybody that delivers health care to patients, nursing homes, doctors, nurses. To put this another way, the one payer, a government agency, it could be federal, it could be state, the one payer does not funnel money through insurance companies. So they can take 15 to 20% off the top and send the rest to doctors and hospitals with strings attached. That's not a single payer system. I helped found Healthcare for All Minnesota in 2015. I was on the original board for a couple of years, and now I sit on HCAMN's policy committee. I've been involved with healthcare reform since the early 1980s. I was working at the time as the lead organizer in Mankato with a group called Minnesota COACT. And in the early 80s, the recession really hammered rural Minnesota particularly hard, and farmers in particular. And there were a lot of farm foreclosures. And COACT got involved with Paul Wellstone, working to stop farm foreclosures. And in the course of talking to stressed farm families, we learned that one of the first things stressed families do is either drop health insurance, which is a big ticket item, or they buy health insurance with large deductibles, which can often make the insurance virtually useless. So we had a sense that the healthcare crisis was coming before the media started paying attention to it in the late 80s. HCAMN's long-term goal, again, is single-payer, universal coverage at the state or federal level, whichever we can get done first. At the federal level, our chief author in the House is Representative Pramila Jayapal from Washington. In the Senate, it's Bernie Sanders from Vermont. Here in Minnesota, we call our single-payer bill the Minnesota Health Plan. The chief author in the Senate is John Marty. In the House, from Roseville, and in the House, Representative Liz Ryer from Egan. But our immediate goal is to protect Minnesota's Medicaid program, which is called medical assistance here in Minnesota, from the enormous cuts proposed by a bill passed by the U.S. House of Representatives on May 22. That bill calls for a cut in federal funding for Medicaid nationally on the order of $800 billion over the next 10 years. And as I think all of you know, that ever since states began to implement their Medicaid programs in 1966, the states and the federal governments have shared the expenses. So if the House Republican cut of $800 billion over 10 years stands, and there's a lot of opposition to this unbelievable cut, it will translate into an annual cut for Minnesota of $1.5 billion. And to put that $1.5 billion annual cut in perspective, we spend $18 billion a year on medical assistance. So it's a substantial cut if it stands. Now, if a cut of that magnitude or anything approaching it stands, the legislature in 2026, our legislature, is going to have some unpleasant options and then one good option. And I'm going to spend most of the night talking about the good option. And here are the unpleasant options. The legislature can cut eligibility for medical assistance. They might, for instance, stop covering emergency care for undocumented immigrants. They might cut benefits. They might cut reimbursement rates to doctors and hospitals, which are already very low. They could raise taxes, and depending on which taxes they raise, then they might worsen the tax burden and shift it down toward lower income people. Here's the one good option they should pick, and they should do this regardless of whether the Republicans are proposing to cut the federal contributions. They should remove the HMOs from our medical assistance program and our Minnesota Care program. We call that, many people call that process, the process of kicking insurance companies out of public programs, deprivatization. Deprivatizing those two programs, medical assistance and Minnesota Care, would save Minnesota about $1 billion a year. So you can see that savings of $1 billion a year would entirely offset a $1.5 billion cut, thanks to House Republicans, but it would be a substantial buffer. A bill was introduced to do just that earlier this year. As you know, the session is winding down. The Senate bill is SF 1059, and the House bill is HF 255. The chief Senate author again is John Marty, and in the House it's Representative Tina Liebling from Rochester. John Marty wrote this deprivatization bill, and he gave it the name Patient-Centered Care Bill. And that's appropriate because patients will be more in charge of their health care, Medicaid patients and Minnesota Care patients, if we can get the HMOs out of everybody's hair. But I'm going to refer to the bill as our deprivatization bill, just because patient-centered care is nice, it's accurate, but deprivatization tells you what this bill is going to do. We need your help here in Senate District 51. And the reason we need your help, we need people's help in all 67 Senate districts, but we need your help here really badly because the senator here is Melissa Wickland. And she chairs the Health and Human Services Committee in the Senate. Any health-related bill has got to go through, got to clear that committee. We know that Senator Wickland supports universal coverage. I have no doubt she's sympathetic to what we're trying to do. And she was a co-author of our state single-payer bill, the Minnesota Health Plan, last session. Now, I checked this session, didn't see her as a co-author. This session, I don't know if we should make anything of that. But she has not signed on to the deprivatization bill that was introduced a few months ago. So I'm going to devote most of my talk tonight to helping you communicate to Senator Wickland why she should support our deprivatization bill. Now, in the course of educating yourself about this deprivatization bill, you're going to learn 80–90% of the case for single payer. Because basically you're going to learn why insurance companies drive up costs so much. And when you get rid of them, you bypass them, which is of course what a single payer does, just bypasses all of them. You save a ton of money. But we need to be able to communicate to legislators, here's why. My wife and I, as I said earlier before you all got here, we live just north of Crosstown. And we're going to be, I and several of my fellow travelers with HCAMN are going to be meeting with the reps and the senator from our district, just north of here, which is Senate District 63. And we're going to be basically telling them exactly what I'm going to be telling you tonight. This is why we have to deprivatize. It's always a good idea, but it is so urgent now that we've got this vicious cut in Medicaid funding that will probably be sustained in some fashion by the Senate. So I'm going to be involved in all the meetings with Senate District 63 folks, and I would love to help you prepare for a similar meeting with Senator Wickland. And I'm not assuming that you're going to grasp all of this in one sitting, so when I'm done talking, let's talk about your interest in next steps to develop a meeting with her. We are unfortunately not in a district, fortunately or unfortunately, where we could lobby some members of Congress who need to be told, do not cut Medicaid like this. Both of Minnesota's federal senators and all the Democrats in Congress are as opposed to Medicaid cuts as all of us in this room. All right. Now, unfortunately, I'm going to have to start looking at this thing as I talk. I want to start by defining some jargon. I already told you that Medicaid in Minnesota is known as medical assistance.
Kip, are you sure you don't want the chair?
Well, can people see me?
I think we could see if you're sitting.
Yeah.
I'll tell you what, I'll stand for a while and then I'll sit.
There's also tall chairs out there.
I'll sit in 20 minutes.
Okay.
Thank you for offering. Our Minnesota's medical assistance program insures a fourth of the Minnesota population. And so you can see right away that a cut in a program that serves that many people is gonna have an impact on an awful lot of our hospitals and clinics. In other words, these cuts to Medicaid will influence the care that many of us who are not on Medicaid are gonna get. I just want to point out before I forget, Medicaid is currently privatized. If you're eligible for Medicaid and you apply, they give you no choice. You have to be assigned to an HMO if you want Medicaid. If you don't want like HMOs, kiss off your Medicaid coverage. But the exception is 200,000 elderly and disabled people. Somehow our legislature, which thought it was okay to cram everybody else into an HMO, thought, probably dangerous to make HMOs take care of the really sicker Minnesotans who are elderly or disabled.
Is that the elderly waiver that you're talking about?
No, I'm talking about the legislature's decision back in the 90s about who to privatize. And as they had that discussion, I don't think they ever thought about pushing really sicker people into the HMOs. But I point that out because one of the arguments against our deprivatization bill is going to be, oh, the government doesn't know how to run a program without the help of the HMOs. Bump. They did it from 1966 till the mid-90s, and they're still doing it for 200,000 elderly and disabled people. Minnesota Care. That is a program for people who are too well off for medical assistance, they're under 200% of the poverty level, and they cannot get employment, insurance through employment. Now that program, Minnesota Care, only insures 2% of the population. So you got medical assistance, you share a quarter. Thank you for all the trouble.
This is just an accident way.
Yeah, right.
That way we can all see you. It's Chris, thank you for your idea. It's a tall chair.
It's a crowd surfing chair.
It's a crowd surfing chair.
Oh,
There we go. Perfect.
I sent it around the room. Did you sign it? Okay.
It's going.
okay.
San Juana? I think this is everything.
So anyway, given the size of these programs, the major savings are going to be coming from the deprivatization of the medical assistance program. Only a tiny little slice is going to come from kicking the HMOs out of Minnesota. The Department of Human Services, or DHS, is the agency that administers Medicaid and Minnesota Care. Its former name was the Department of Public Welfare. And I'll have occasion to talk about the Department of Public Welfare when we get into the history of how HMOs got inserted into medical assistance and Minnesota Care. You've heard me use the word privatize. Privatize simply means shifting the administration of a public program to the private sector. Medical assistance was gradually privatized between 1985 and 1996. It didn't happen all at once. But Minnesota Care was privatized bingo overnight in 1996. I don't know what got into them. I have some theories. We can talk about it in the Q&A if you like. Medicare Advantage is the misleading title of the privatized portion of Medicare. And I'm going to badmouth Medicare Advantage from now till the cows come home, but I want to make it crystal clear, I've got relatives in Medicare Advantage, and I'm not criticizing anybody that signed up. Because they're overpaid, they can offer excellent benefits, and it's often cheaper to get your insurance through a Medicare Advantage plan. But we need to deprivatize Medicare Advantage as much as we need to deprivatize Medicaid. Managed care. It's a term that emerged in the mid-'80s to describe the collective, to serve as a label for the tools, the cost containment tools, pioneered by HMOs. And those tools fall into three categories: limiting the patient's choice of a doctor in a hospital, exposing doctors to financial incentives to deny services, and lastly, to the extent that the first of the tools.
I'm sorry.
Even the phone is objecting. Oh, man.
Third,
Cost containment tool referred to it, but with managed care, is micromanagement of doctors. Prior authorization being the most obnoxious and common form of meddling in the doctor-patient relationship. These days, HMOs are typically called MCOs, managed care organizations. So, sorry to have to keep using new jargon. The reason we say now managed care organizations instead of...
Sorry, I did turn it off.
You're all right. The reason we say MCOs instead of HMOs most of the time now is that as the 80s and 90s went by, and the HMOs were using these cost containment tools, plus their large size, to keep their premiums 5 to 10% below the traditional insurance companies. Traditional insurance companies go, whoa, we can't keep losing market share of these characters. We got to mimic them. We got to copy them. And so most traditional insurance companies, Blue Cross, Prudential, all began to use all or some of the managed care tools. And so by the mid-90s, it just made no sense to try to distinguish HMOs from traditional insurance companies. And so since the mid-late 90s, everybody says MCOs, we don't use that term, but the federal and state laws still have the words HMO on the books. So depending on whether we're quoting a statute, what time in the history, you will hear me say MCO or HMO. And lastly, self-insuring. Self-insuring refers to a big corporation, General Mills, John Deere, deciding we're done insuring our employees through an insurance company, United or Blue Cross or Health Partners. We are not going to pay their insane administrative costs and their big profits. We will set aside enough money in our own bank account to pay the bills of our employees as they come due. We will be our own insurer. Self-insuring spread rapidly in the 80s as the costs went up. And you know darn well the American businesses didn't do it just because they love self-insuring. They did it because it saved them money. That's essentially all we're asking the state and federal government to do for everybody else. If employees of big Fortune 500 companies can benefit from self-insuring and not have to have an HMO looking over their doctor's shoulder, how about the rest of us? All right, I think I'll probably run into a few more jargon words, but so my main goal tonight is to explain why removing MCOs, HMOs from Minnesota Care and medical assistance will save about $1 billion annually. I will have only a little time to offer a brief overview of the impact of privatization or deprivatization on quality. That's a hugely important issue, but we have to prioritize. And what we're saying to our legislators between now and 2026 is you have to save $1 billion now because these cuts are coming through and the alternatives are terrible. So we're emphasizing cost, and that's what we're prioritizing. But you know darn well the insurance industry is going to come back with, oh, well, look what happened to quality. We coordinate care and blah, blah, blah. So I don't want to dismiss the issue. We do need to talk about it, but the cost issue is what I'm going to focus on tonight. I want to start by talking about 3 clear-cut examples to illustrate how expensive it is for any payer, be it Medicare or Medicaid or Minnesota Care or General Mills or 3M, to funnel money through an insurance company rather than pay doctors and hospitals directly. Now that's exactly how I just described a single payer. So you're already seeing how, in talking about the benefit of deprivatizing, you're grasping why a single payer saves money. The first example I'm going to give you is something called the Buyers Healthcare Action Group. That was a coalition of 25 big Fortune 500 companies in Minnesota. And I know you can't see this, but this is what my slide would have showed you. It's an excerpt from an article in Business Week magazine in 1993. The author interviewed Steve Wetzel, the director of the Buyers Healthcare Action Group. This group of 25 big Fortune 500 companies said, to heck with the insurance companies, we're going to self-insure. And guess what? They saved a ton of money. And the way Steve Wetzel put it, was, we were wasting millions on HMO administration. And he said we cut our costs by 11%, right away after 1993. And you can imagine why, because the components that they're no longer paying for, they're not paying for insurance industry advertising, the cost of insurance industries of harassing doctors, of putting together networks every year so that you're pinned in, lobbying, huge management salaries. I know I'm missing something, but you get the picture. Why would anybody pay for all that if you didn't have to? Second example I want to give you is a very recent and really encouraging example. Connecticut, like Minnesota, privatized their Medicaid program in the 1990s. They stuck HMOs in there. And it's a fascinating story of how the governor was persuaded to deprivatize. I don't think the legislature was involved. I think it was entirely a gubernatorial decision, Governor Malloy. They deprivatized in 2010. Boom. I think it was 8 HMOs gone. They're no longer in the Medicaid program. Now here's where I wish I could show you a graph. But the Medicaid agency in Connecticut, just before last Christmas, released a report on the new deprivatized program. And in it they said it is a model of efficiency for a state Medicaid program. They said we have saved 14% compared to surrounding northeastern states that are still privatizing. And they improved health. And I can't show you the slide, but I'll ask you to visualize it. Visualize 2 slides. First, visualize a slide showing, and this is one of the few quality slides I want to show you, a slide showing the percent of cancer diagnoses that are where cancer is diagnosed early. And the definition of early diagnosis was the tumor is at stage 1 or stage 2. Don't ask me what it means. I just know stage 1 and stage 2 is early, and stages 3 and 4 is late. And a study was done by doctors in the University of Michigan of the Connecticut experience. I think they were all oncologists. And they showed a dramatic increase in the percent of early cancer diagnoses immediately after they got the HMOs out of the Connecticut Medicaid program. And the mortality rate from cancer dropped by 8%. I forget how quickly, but it was rather rapid. I just love to show you this neck mass. One of the co-authors did a PowerPoint on this study, and he showed a patient in Michigan's Medicaid program with an enormous neck mass about the size of my fist under his right ear. And he said, we wanted to get a CAT scan on a lump that big. That's the normal next step. His MCO delayed the CAT scan for 3 weeks, and then the referral to an oncologist for 2 more weeks. A long, long delay. The doctor didn't say whether it turned out to be a tumor, but Kip Sullivan's uneducated opinion, it sure looked like a tumor to me. But you can see then why, with this love of prior authorization that all these insurance companies have, that you could worsen the mortality rate for cancer if you keep the insurance companies in Minnesota's Medicaid program. What on earth would justify our doing it? We certainly aren't saving money. Next example, clear-cut example, I've already mentioned it to you. These Fortune 500 companies that gathered together and self-insured in 1993. I forgot to show you, I don't know if you can see this, the title of this Business Week article about the Business Healthcare Action Group's decision to self-insure was entitled Minnesota's HMO-ectomy.
Minnesota HMO what?
Minnesota's HMO-ectomy. I think we will start referring to, we want to an HMO-ectomy and that probably communicates faster. So anyway, I've already told you the outcome. The article basically said, they quoted Wetzel, and Wetzel said we're wasting millions on HMO administration. Now I turn to the last clear-cut example that illustrates the high cost of payers funneling their money through an insurance company, and I'm turning now to Medicare Advantage. What I have here is an excerpt from the latest report from the Medicare Payment Advisory Commission, MedPAC for short. They were set up, losing track of time now, 30 years ago to advise Congress on everything having to do with Medicare. And every March, they issue a report on the status of Medicare, and they include a chapter on Medicare Advantage. The latest chapter on Medicare Advantage, what is today? 2 months ago. I'll read it to you. They say, in 2025, we estimate that Medicare will spend 20% more for Medicare Advantage enrollees than it would spend if those beneficiaries were enrolled in fee-for-service Medicare. Now, fee-for-service Medicare is often the label used to describe the traditional Medicare program, where basically half of all Medicare recipients are today. I had known about this overpayment for eons, and I've been gritting my teeth about the inattention paid by Congress and the media. I was part of a group working with Physicians for National Health program that actually looked at 5 causes of overpayments to the Medicare Advantage plans. And we concluded that the overpayment, we released a study in the fall of 2023, we concluded that the overpayment isn't just 20%, it's 35%.
Well,
But it's worth quoting MedPAC because they have so much credibility with Congress. And the main reason they do is you can't get on the MedPAC commission if you aren't dedicated to privatizing Medicare. So for them to come out and admit that
Wow.
it's good ammunition for us. I will skip over, here's one other quote I want to give to you. This is from the March 2022 MedPAC report to Congress on Medicare Advantage. In it, they said, the Medicare Advantage program has never produced savings for Medicare.
has never produced what?
Savings,
Oh,
never. Not 1 year, yes.
Is it, in the comparisons, are they comparing, what's, covered as far as dental and, other things that, the Advantage plans cover versus the things that, traditional Medicare covers? I mean,
Well, what we looked at was, the reason why that's a hard question to answer is you don't know,
Yeah.
after you give insurance companies money, what they do with it. They're a black box. Now, they say they'll cover dental, but if you actually look at the number of people insured by a Medicare Advantage plan and ask, how many of you use your dental services, it's very small. I can't remember exactly what it is. So the short answer to your question is, what they do is they ask the question, if we were, because that was the argument that the early HMO advocates paid for inserting HMOs into Medicare. Congress did that back in 1972. And the argument was the HMOs will reduce the cost of insuring every Medicare recipient that we can persuade to leave the traditional program. And they didn't say, well, it will cost the same, but we'll also offer dental and eye and ear care. And it's that comparison. So if the average cost of a traditional Medicare recipient is $10,000, these comparisons then ask, well, how much did we pay United Healthcare and Humana and Group Health? Well, by the time you adjust for health status, which is one of the tricky questions because they usually get much healthier people, but when you make that adjustment, that's where you begin to discover the enormous overpayments. Because when Congress first inserted HMOs into Medicare, they weren't thinking, it didn't occur to them, oh, most sick people aren't going to want to give up choice of doctor, so the HMOs will attract healthier people, but what the heck, let's pay them as much as if they were still in traditional Medicare. It's a bit of a long-winded answer, and I'd love to continue this discussion because all of us need to understand this issue and others in order to make a good case. I mean, our senators are not on board with deprivatizing Medicare. We've got a lot of work to do with them. Anyway, what we'll say here, and just for the sake of making it clear, no matter which of these instances you look at, if you funnel dollars through an insurance company, which is what Medicare Advantage does, rather than pay doctors directly, you lose your shirt. You do not get anything back for your money that compensates for the extra costs. I can't show them to you, so I'm going to skip over similar reports from U.S. General Accounting Office, which since the late 80s is periodically banging the drum. They say the same thing in Congress. We are overpaying the HMOs, as they said back in the 80s. Now, what I'd like to show you is the next graph. I don't know if you can see it, but it's a dollar bill.
Yeah.
And the graph, I don't know, you can't see the numbers, but it's a dollar bill, and the graph is prepared by America's Health Insurance Plans, the trade group for America's bloated and predatory health insurance companies. And this graph was cited in the Journal of the American Medical Association article, so it's from the horse's mouth. And even according to AHIP, only 80 cents of the dollar we give to an insurance company goes to doctors and hospitals and pharmacies. The other 20% gets eaten up by profit and administrative costs. And I enumerated some of those administrative costs earlier. Marketing, telling doctors how to practice medicine, etc.
Can you show us the graph again and tell us which colors are the 20%?
The 20% figure is that, what color is that?
Yellow?
It's yellow brown, yeah.
It's the lighter orangey color.
So that light orange block eats up 20% of this dollar bill you see on the screen. That's what you give up when you run money through an insurance company. I'll skip another slide, a similar report. The Centers for Medicare and Medicaid Services, or CMS, is the federal agency that runs Medicare and Medicaid. And they issued a report under the Bush administration making the same statement. They said the admin and profit costs eat up 24% of the average dollars you give to any insurance company in America. Now, we're getting closer now to the case for deprivatization. When an insurance company participates in a public program, Medicare, Medicaid, and Medicare, the percent of the money given to it that is eaten up by administration and profit drops. It's no longer 20%. It now drops to somewhere in the range of 15%. I've got a couple of slides here that quote, first of all, MedPAC saying that in 2024, the administrative costs ate up 14% of the money given to Medicare Advantage plans. I have another slide here from the National Association of Insurance Commissioners saying the same thing. The insurance company participates in Medicare, eats up 14% of every dollar you give it on administrative costs and profit. The National Association of Insurance Commissioners also says that the number for Medicaid MCOs is 12%. Now, why might an insurance company have to devote a lower amount of money to administrative costs when it participates in a public program? Well, I've never seen research on this, but my common sense tells me it's because the government is now collecting revenue for the insurance company. And so the insurance company is not spending money on revenue collection. The other question to ask is why might Medicaid's MCO's overhead be 12% and Medicare MCO overhead is 14%? I haven't seen studies on this, but here's, I think is a good guess. When states privatize their Medicaid programs, they don't consult the low-income people who are going to be most affected. They say, you will go into an MCO, you will have to go into an HMO, or kiss your Medicaid coverage goodbye. Congress never treated the elderly that way. Congress always gave the elderly a choice. They could stay in the traditional Medicare program, or if they wanted to, and wanted to risk worse care, they could sign up with a Medicare Advantage plan. So you see the difference. The Medicare Advantage plans have an immense incentive to advertise to get more and more seniors and disabled people to leave the traditional Medicare program and go into Medicare. If you haven't been sleeping under a rock, if you haven't seen Joe Namath and God knows how many other people yakking at you on TV, enroll in the Medicare Advantage plans. Anyway, so I'm going to talk about the typical overhead cost, administrative cost of any MCO that is participating in any public program, Medicare, Minnesota Care, Medicaid. I'm going to say it's 15%, not 12 or 14. And that's a simple reason for that, and that is all the scorekeepers, CMS, National Association of Insurance Commissioners, they allow the insurance companies to count so-called quality improvement activities as medical expense. So somebody sitting in United Healthcare skyscraper, dreaming up quality improvement activities, is doing something like what a doctor does to you when you're in a doctor's office. It should just make you squirm. And I don't know what percent of the so-called quality improvement activities get dumped into medical care expenses. And just to be conservative, I'm upping those two little numbers, 12%, 14% to 15. So we can be fairly confident that that's a solid number. It may be higher. Now we're ready to do some arithmetic to figure out the savings we can get by deprivatizing medical assistance in Minnesota care. We start with this 15% administrative figure, overhead. As soon as we get rid of the insurance companies, we're going to get to enjoy the savings that the Fortune 500 companies did and Connecticut has, and that'll amount to 15% of the billions we give the HMOs now. So that's, we can count on that. But there's two other numbers, one we have to have. We know that the MCO, the Congress in Minnesota inserted MCOs into public programs because the HMOs came and told them, these darn doctors are ordering services patients don't need, and that's why God created HMOs. We'll go out there and we will make sure they cut back unnecessary services, and only unnecessary services. God forbid we'll never harm a patient. Well, again, we don't have good research on how much the MCOs reduce utilization of services. I won't show you the slide, but the research we have suggests that the reduction is on the order of 0 to 5% of total spending because of reductions in total services. Who knows what the expenses are down the line? If you didn't detect cancer in time, now you've got bigger expenses, but 0 to 5% is probably the best estimate. So somewhere, if you take the 0 and 5% and subtract it from the 15% savings for administrative costs, now you've got a net savings of 10 to 15%. That's basically what we're working with. And that $1 billion a year in savings that I told you about earlier, that's kind of right in the middle. So if we get a 12% net savings, we can roughly count on $1 billion saved. There's a third number we'd like to have, and this is where Senator Wickland can help us. The third number we'd like to have is what happened to DHS's overhead. Because it's really difficult to regulate these HMOs. The money disappears into black boxes. We know that before Medicaid and Minnesota Care were privatized, DHS would use up 4 to 5% of the money they got from the Minnesota Treasury just to run their own shop. You gotta hire people to accept applications and determine whether the pickup is used for fun or for work, what the income eligibility is, you gotta process claims, you need staff. And they were spending 4 to 5% of every dollar they got from the Minnesota Treasury on DHS overhead. We suspect that number went up after privatization, or it should have, and then maybe they didn't because they weren't enforcing anything. We have asked DHS twice, nice, polite letters, and they have not answered us. They give us cordial replies, but they don't answer us. So those are the only two numbers we have to work with at the moment. Is 10%, 15% saved on administrative costs, and 0 to 5% offset due to possible increase in utilization. One last comment. I've already been wise-aching about this, and you know what I'm going to say. That 0 to 5%, I don't know quite how we should talk about it, but I know darn well we should not talk about it as if somehow that was good money saved. And the research on whether that 0 to 5%, how much of that is due to cuts in necessary services is not good. But I've got a slide here from some experts who say about half of it was cuts in necessary services. And the other half was low value or perhaps not necessary. But you know darn well that these people cannot look down from their skyscrapers with their x-ray vision into the examining room and go, we up here in the insurance industry nest, we can look down and tell you that this statin should not be ordered, this patient should be kicked out of the nursing home after 12 days. That's their line, and they've been getting away with it for almost half a century. I've got a bunch of slides here on in my appendix. I'll just give you one more slide on the quality issue. Consumer Reports looked at the research on Medicare HMOs in the mid-90s, when it was all the rage to shove all Medicaid programs into HMOs. Well, this is what Consumer Reports said in an October 1996 article after examining the research on Medicare HMOs. Most people are better off staying in traditional Medicare. If you have chronic care needs, HMOs are clearly not the place to be. Pop quiz. What's the administrative overhead for an MCO in a public program?
14%.
Yep. We're going to say 14%, and we'll bump it up maybe 1% or so to reflect the game playing with quality improvement.
What did he win?
You can have another slice of pizza.
My immense respect. I'm throwing you a lot of numbers. I hope everybody's tracking. But I want to give you one more number before I move on. What would you guess is the overhead of the traditional Medicare program? I told you earlier that DHS's overhead prior to privatization was only 4 to 5%. Any guesses as to what the traditional Medicare program overhead is as a percent of revenues? I won't make a guess forever. It's 2%.
Whoa.
You give traditional Medicare dollars worth of taxes and premiums, they keep only 2 cents to run their shop versus the 20 cents that it takes United and Humana and Group Health and Health Partners.
Now, on that topic, Medicare, very often HMOs or clinics or whatever, they are taking their CPT codes. Those CPT codes are being billed at Medicare rates or equivalent to that. Is that true of all MCOs? Is that how they are paying? Do they follow Medicare rates? I know they did in my audiology business, so I don't know about others.
Boy, this is a complex question. Are you asking, do they pay doctors and hospitals the same rate that doctors and hospitals would be paid by CMS for treating traditional
Correct,
Medicare?
that's exactly what I'm asking.
And I think we don't know the answer to that, again, because they are such opaque black boxes.
Right.
We don't know the answer either in terms of Medicaid MCOs here in Minnesota. And we're gonna need to know that when it comes time to kicking the HMOs out, because they're gonna squawk, and we need to know whether they are actually punishing doctors, paying them more. It would be very useful information to have. But that question is, we should come back to it and do a presentation on deprivatizing Medicare, because there's so many games that the MCOs play to increase their reimbursement levels, even beyond the favorable selection we were just talking about 10 minutes ago. Yes?
Don't they, the insurance companies bargain with the providers, with what the rates are what they're gonna pay them?
Yes. Yes.
So we don't even know, I mean, they don't say, we'll pay you the same as Medicare does. They say, we'll pay you X% of your costs,
Well,
or
they'll
we'll pay
often-
you however they do it. But I mean, they bargain, so it depends on which provider they're reimbursing.
And the other wrinkle is, they include incentive payments in whatever the payment. So let's just assume that the answer to your question is, the MCO, the Medicare Advantage plans pay exactly what the doctor would be paid if the doctor was treating a traditional Medicare beneficiary. Let's just assume that.
Okay.
But the MCOs, their game is to insert incentives to get doctors to deny services. So they include bonuses, and they track the utilization rates, and they send around letters to everybody in the doctor's network saying, Dr. X only ordered 3 MRIs, you fool ordered 8 per patient or whatever, and then they issue rewards based upon how well the doctor kept utilization done. So you can see why it's a hard question. They're black boxes, and they've got these incentives built into the payment systems I've seen people try to find out from DHS, what are you paying the HMOs, and then what are the HMOs paying doctors? And you might as well be talking to the wind. Because Minnesota passed a law saying DHS doesn't have to share that information. All right, pop quiz, 15%, but that 2% number becomes very useful when you're making the case for single payer, right? And so, tucking away, and let's have another meeting to talk about why we need a single payer at the federal and state level. All right, so to sum up what I've said so far, we've looked at 3 examples that clearly illustrate the high price any payer, Medicare, Medicaid, big business pays when you funnel dollars through an insurance company. Connecticut, self-insured, Medicare Advantage. And we've talked about why that's such a high cost proposition. It's because the average insurance company is going to set aside 20% of whatever you give it to pay for administrative costs and profit, and in the public sector, 15%. Now, we could stop here, and I think for most people, this information I've already given you is compelling. You would just say, look what Connecticut did, look what happened with the Virus Health Group's Action Group, look at the insane amount of money we're paying Medicare Advantage, discussion over. But who in their right mind wants to continue privatizing Medicaid? I think for most people, we could stop here. But there's a lot of people in the legislature that drank the managed care Kool-Aid. And I'm going to now describe another nail in the coffin. Sanquan, how much more time should I take here? I've got 6:22.
My suggestion would be, I mean, you're leading the presentation. My suggestion would be maybe do another few minutes and then open it up for questions and then start again.
Okay.
Does that make sense?
All right.
Okay.
What I wanted to do here is to tell you how doubtful the original HMO advocates were when they came to Minnesota to suggest privatizing Medicaid. When you look back, and I think you won't believe what I'm going to tell you, but I have the original documents here. I flagged what I want to tell you. You're going to think I made it up. But I need to introduce you to some of the players and their rationale. So very quickly, I want to get you from roughly 1970, which is when a Minnesota physician named Paul Elwood first started selling the idea of health maintenance organizations to Fortune 500 companies here in the Twin Cities and to people in Washington, D.C., starting with Nixon and his representatives. And we will see why he thought HMOs were such a wonderful idea. But when we get to the early 80s, when Reagan now wants to privatize Medicaid, and Reagan announces, I want states to apply for permission from us to start experimenting with HMOs and Medicaid. Not good enough just to privatize Medicare, which they started back in 1972. We got to privatize Medicaid. And Elwood, being from Minnesota, had a think tank out on Christmas Lake, and now he's famous because he's the founder of the HMO. Elwood gets wind of what Reagan is proposing, is going to propose, late in 1981, and he writes up a proposed application, and he sends it over to the Department of Public Welfare, which was the old name for DHS. And he proposes what on its face is a rigorous test of whether HMOs in Medicaid could work as advertised. And the rigorous test was, that he proposed to DPW, the Department of Public Welfare, was DPW will propose to the Reagan administration, we will select 3 counties in which we will force Medicaid recipients into HMOs, whether they like it or not. And we will run that experiment for 3 years. And we will collect wonderful information from the HMOs. And when the 3 years are up, we will compare the HMO performance on quality and cost to the performance of non-HMO doctors in hospitals in adjacent counties. So you can see how on its face, this is a really rigorous test of the HMO concept. The HMOs hadn't faced a test like this. So when I first heard Well, in Elwood, he had no reason to propose HMOs to the next administration. He had no reason to say to the Democrats, we will save money if you insert HMOs into Medicare, which they did in 1972. And there's nobody saying to them, well, let's do a test first. No, let's go ahead and put HMOs into Medicare. Well, now Elwood is saying the same thing for Medicaid, only now he doesn't just get to sound off. He's proposing a very rigorous test. They're going to compare Medicaid HMO performance in Hennepin County to the performance of non-HMO doctors in an adjacent county, Ramsey. Well, what happened? Well, and I'm skipping a lot of the history here, we can come back to it in Q&A if you like. What happened is, and this is why I have copies here in my big book, Elwood said in his proposal to DPW, November 1981, let's rig the experiment. That, of course, is not what he said, but I'll read to you how he wanted to rig it. He said, number one, the HMO should be allowed to exclude any patient who fails a health screen. Number two, the state should purchase stop-loss coverage for the HMOs to protect them from inpatient hospital services exceeding $5,000 per patient per year.
5,000?
Yeah. Are you going to do that for the doctors in Ramsey? If you do that. And the third, and probably the most laughable method of rigging he proposed was unauthorized utilization, meaning out-of-network care, will become the responsibility of the state.
Oh.
I think he would have been embarrassed, but I kid you not, I've got a copy of the proposal. I had it, by the way, and then I've got a copy of DPW's proposal. So they went, oh, this is great. And in April 1982, DPW, at the time under the Quay administration, the Republican governor, they wrote up a proposal that was longer and more detailed. And they didn't pick those same three methods of rigging that Elwood did. Here was their method of rigging. And I've got some stick notes on where they said this. DPW should be allowed to reduce the benefits that HMOs must cover. They just might run out of money because they got 50% overhead and they're full. So that's what DPW submitted. And basically a proposal for a rigged experiment. The agency that approved it is called HCAMN, Healthcare Finance Administration. The old name for CMS, Centers for Medicare and Medicaid Services. And DPW selected Hennepin County and Dakota and Itasca as the three counties where people would have to be forced into HMOs for 3 years. And they submitted the final plan to HCAMN in March 1985, and they got approval at the end of that year. Everything went well, right? In 1987, turned out the HMOs didn't really want to turn over the data. The DPW had promised to the federal government, we will collect in order to evaluate the performance of the HMOs and compare it to the doctors and the non-HMO doctors. And so DPW asked HCAMN for an extension beyond the original 3 years. HCAMN said no. I would love to know exactly what they said, and I've asked DHS for the exchange that followed. For some reason, DHS was able to give me the original. I had to pay $50. It's not in any library. I had to pay money to get it. They've got the original Elwood proposal, and they've got the DPW 1982 proposal, and that's it. So all I can tell you is that come 87, the HMOs weren't cooperating. DPW says, can we have an extension? And HIPAA refuses. You would think that would have been the end of the HMO privatization juggernaut. No, somehow somebody got to the legislature and Congress, and both bodies passed laws that said, no, heck with it. We want to privatize. So privatization proceeded. By 1996, it was completely, the whole state, both boards of Minnesota Care and the assistants were completely privatized.
I'm a plant. I am wondering if you could just mention about the report and the leak.
I was coming to that.
Oh, okay. Dang it, I gave it away.
Let's see what I have. Oh, yeah, here it is. So in 1992, a DHS employee who promptly lost his job, a DHS employee named Stephen Foles, tried to make one last attempt to use the data they did have from the privatized and the control counties. And he said, I'm working on the insufficient data, but the report did not shine a good light on the HMOs. And guess what? The HMOs went to Arnie Carlson's DHS commissioner, blanking on her name now, and said, suppress this study. And for about a year, it succeeded. The study never saw the light of day. But we know about it because in March 1994, someone linked the study, or early in 1994, someone linked the study to the Star Tribune. And on the front page, I think it was March 13, 1994, big headline said, study shelved after HMO's blank. Who would have thought? Now let me read you just one excerpt from the article. This is precious. The documents obtained by the Star Tribune include a memo from a DHS staff member expressing concern that the HMOs had responded to the upcoming study by, quote, taking the offensive and believing that as usual DHS will cave in. The memo also said that some HMOs, quote, have a vested interest in keeping information from DHS because a large profit currently is being made, which would be revealed if the data were submitted accurately. Well, immediately after this expose, the legislature went into it. They held numerous hearings saying, what's going on here? And DHS said, oh, we're sorry. Joking. Nothing happened. That's how deeply ingrained this HMO mythology has become by the mid-90s. You don't need no stinking evaluation of the HMOs. And what the heck? So what if the HMO suppressed the study? In the summer of 2004, I'm getting now to the end of our effort to find out, did you guys ever ask me, say no? In the summer of 2004, and by this time, San Juan, you might have been working with the Minnesota Universal Healthcare Coalition.
Probably.
5 or 6 of us joined a meeting with then Minority Leader Matt Intensive. That was August. And we said to him, Matt, will you just write DHS, you're a legislator, ask them, do you have any evidence that privatization saved money? And he did. The commissioner at the time was Kevin Goodman. It took a while for Goodman to answer, and here's what he wrote back. There no longer remains a credible comparison group of fee-for-service recipients against whom to compare the groups now enrolled in managed care. We do not have a methodology that could accurately assess whether managed care has cost us more or less than fee-for-service. Have a nice day. That's as much, and that's where we are. And we've asked DHS now in the last year, HCAMN, in the last year several questions. Tell us what the overhead of the average HMO is. Tell us what your overhead is compared to the 4 to 5% it was in 1990. Cordial responses, we will be in touch. And no answer. So I will stop here. I've given you 2 nails for the MCO coffin. One is these 3 instances where payers paid dearly for funneling money through insurance companies. And I've told you why. Enormous administrative costs, 20 or 15% depending on what market you're talking about. And nail 2 is the brazen willingness of Paul Elwood and the early HMO advocates to propose privatizing Medicaid, but only if we rig the experiment. And even with a rigged experiment, the HMOs wouldn't cooperate. Now, I feel, when I first saw it, I feel like the lawyers working for the Dominion, what was the name of the election company? Dominion, yeah. Remember when they discovered the emails amongst Fox News executives admitting that they knew everybody, their so-called news anchors were lying. Well, case closed. We got the same thing here. The founder of the HMO is so unsure about how his HMO will perform in the real rigorous test. He wanted to rig the test. So, we have much more to talk about. We haven't talked about quality, but I'll stop here. We can take questions.
Obviously, it's all money. Follow the money, and you're gonna know why this all happened. The whole purpose of HMO, PPO, meaning the just getting out of high school at that time, was the entire fact that they said it's going to be huge cost savings. The doctors are charging us too much. And I think most of us would throw up their hand, my parents would throw up their hand and say, it's true. Doctors are charging us a lot of money to go in and get care. Not necessarily a savings. HMOs, PPOs, are we just took the wall from here, put it over there, restricted the kind of care we can get because the doctors have no control of their patient care any longer. And maybe they were overprescribing tests. We certainly know that MRIs get overprescribed, certain things get overprescribed, but it's not with any kind of relevance. I've got colleagues that work at United Healthcare, scary business. Optum is even worse. And they start looking at what they do and how they manipulate things, not wanting to transfer someone from a nursing home to a hospital because it costs us too much. That just came out and started moving in the West. 8 days or so. But that's the purpose, and I don't see representing cost savings, and don't we have a stat that could be amortized out? What was the cost per patient care in 1976 versus the cost per patient care amortized out, taking into account difference in value of dollars to today?
Well, the value of those three examples I gave you is you've got good comparators. Connecticut can look at before and after deprivatization, or they can compare to New Jersey. Medicare Advantage, like we were talking about earlier, you can compare to a similar group of Medicare recipients in the traditional Medicare group. You can do that today.
How did they get it sold then?
Pardon?
How did Connecticut and New Jersey get this sold?
It was Connecticut that succeeded in deprivatization. Oh, how did they get?
How did they get it done?
I have been begging for the equivalent of someone who will write the best and the brightest. The David Halberstam book about how we got into Vietnam. We need someone to write the best and the brightest about health policy. I do not understand how so many smart people, and people who weren't getting paid under the table, very nice, intelligent legislators, who they bought the argument. There's that little kernel of truth that the fee-for-service method of payment does create an incentive to order services. Well, you don't jump from that to, I guess doctors don't care about the patients, they don't care about malpractice, they have no pride in doing it. There's just no evidence for it, but I suspect that little kernel of truth to a busy legislator, plus one or two examples of actual overuse, and you're hooked. And if healthcare reform in Minnesota doesn't have a lobbyist stalking the halls and bending their ears the way the HMOs do, we lose the battle of the microphones. Yes.
But things have changed so much since the 70s and 80s. I was practicing then. And now we've got algorithms that look at best practices. We've got computer services to say that using the argument from the 70s and 80s and 90s just doesn't cut it anymore. And that's what we need to talk to our legislatures about. There's so many more tools to give us good care and not overcare.
But there was never, I assume we're agreeing, that there was never any evidence for Elwood's diagnosis.
Right.
That the reason healthcare costs are high in the U.S. is that stupid, greedy doctors are ordering services patients don't need. And he had no evidence for his supposed solution to the non-problem. And nothing has changed since. That's basically, so I think the most improvement in quality we're going to get if we can just pull the talons of the big health insurance companies out of the necks of the patients and doctors everywhere, starting with Medicare and Medicaid.
I worked in quality, and so worked for a large institution. We had care managers from the company, We had care managers from the doctor's office and from our hospital. So we had 3 care managers managing one patient, duplicating services. So that's all of the waste that's going on in the quality issue. It's the duplication of services that the insurance companies are mandating.
Yeah, because multiple insurance companies all want to coordinate care.
Yeah.
They all want their own nurses, probably, the
It
hospital.
incentivizes the physicians to do the same thing.
Yep, yeah.
I want, Kip, one of the questions I have, and I know you'll go into quality, because even though we are spending so much on healthcare, the quality is not that good. But my question is, when I Google, the good old Google, they say that one of the number one reasons for bankruptcy, personal bankruptcy in America, is healthcare cost. So since we're on the topic of cost, can you talk to about why on earth is that happening? People with insurance are going bankrupt.
And that gets us into, and I love, when I make the case for single payer, I get into this whole debate, really since 1970, the debate about whether we can afford universal health insurance has been about, well, if you want to insure more people, you have to tell me, the legislator, how you're going to cut costs. And the debate is basically between the people who say the problem is excessive quantity and the people who say no, the problem is excessive price. The managed care people have been saying the problem is all this unnecessary care that these greedy, stupid doctors paid fee-for-service order. The single payer movement, which began to get some muscle and a word in edgewise and started in the late 80s, our position is no. There was never good evidence for the overuse argument. The problem has always been these enormous administrative costs that are generated not just for the insurance companies, and that's all I've talked about tonight, but also for doctors and hospitals who, as the lady was just talking about, they have to spend enormous amounts of money just coping with demands of the insurance companies. So my short answer to the question of why is this happening in a wealthy country is because that debate has been so lopsided. The insurance industry keeps telling everybody, if you kick us out, you're going to see utilization go through the roof, and even people with insurance won't be able to afford it. So my first answer to you is, policymakers have been paralyzed by that overuse argument. They don't dare do anything to control prices, because God forbid that would be socialism. That would be what Trump is telling Walmart to do. We don't want to do that in healthcare. And the prices are high because both administrative costs are high, and because of the spread of managed care, merger maintenance has been running rampant since the 80s. And as I think you all know, anytime you talk about any industry, whether it's dog food or healthcare, as the number of suppliers dwindles, it's easier and easier for them to raise their prices. And if their administrative costs are going through the roof at the same time, they have an immense incentive to raise their prices even more than they would ordinarily. So that's my short answer is we need to educate policymakers on what the real cause of healthcare inflation is. There was a time in the early 70s when per capita spending in the U.S. was equal to per capita spending in Canada. We separated wages dramatically in 1970. Why? Because Canada retained their single payer system, and we endorsed HMOs, our Congress, and Minnesota's legislature did in the early 70s as well. I'm sure there's a lot more to say about that, but that's my quick answer. We've been paralyzed by disinformation. And the problem, just to repeat, it isn't that a lot of our good friends in the DFL have been taking money under the table. It just isn't happening. They bought it, and they're too busy and they're too overwhelmed by the bullhorns from the insurance industry. That's why I'm looking forward to this meeting with Senator Whitman. I'm looking forward to the meeting with our Senate District 63 folks. Because the minute you tell people this stuff, the lights go on. This debate has been going on over our head now for 50 years. The minute you bring it down to earth, people get it.
How does this, sorry,
No, go ahead.
Tied into the admin to the last decade, I don't know, number of years, these high deductible health plans, putting the onus on the member. If I'm told I need an MRI, I'm not gonna shop around, I'm gonna get the MRI right now, or, you know, I think that's just another, in my opinion, evidence of the shifting of the wealth to the wealthy. Yeah.
She's asking the question, why are we seeing deductibles go up more and more and more and more? Because that's quite relevant to San Juan's question, which is,
Yeah.
how is it that in the wealthiest country in the world, we're seeing the cost of healthcare continue to go up to the roof? And one of the other symptoms, not only are the insurance companies just cracking down using prior authorization, they're also selling insurance with bigger and bigger deductibles. I would like to come back and talk about the entire history of the healthcare reform debate. It's useful to remind people that the Republican position all along, and I mean, I'm stereotyping the party a little bit, but it's a fair stereotype. They opposed Medicare and Medicaid when it was passed in 1965. And they really were not part of the debate until the early 90s when the Clintons, when Bill Clinton got elected, and he started banging the drum for universal health insurance. At that point, Republicans in Congress said, no, we don't want Medicare for all, or we don't even want the Clinton plan, which is an HMO for everybody. What we need to do is put the onus on individual Americans to buy their own health insurance with deductibles in them, but connected to a savings account, where if you don't use, and with a deposit in a savings account. So if you imagine that you work for 3M, 3M is going to offer you a health savings account. They say to you, we're going to put $2,000 into your savings account. If you don't spend it, you get to keep it, right? But if you're sick, you can go well over $2,000 and wind up losing big time. That was the Republican proposal. So there's a lot of sentiment out there for this idea that somehow we need to make you shop around. God bless it. You're just told him how to wear the cost of the MRI or the colonoscopy or whatever. And if you were aware of the price, and then you put out report cards.
Yeah.
This hospital does B- work on colonoscopy, but A+ work on deliveries. We all become busy little shoppers. You can be shopping for healthcare, you can be shopping like for ceiling fans or cars. I don't know how many people actually still believe that, but I get regular reports from right-wingers. There's still people that fantasize about, we just got to bring competition to the American medical system. That would be the
That's
ticket.
how it was sold, though. Those plans were sold that you take part in your own health care and then, you know.
Skin in the game.
Yeah.
Skin in the game is also going to pay the phrases. If you know you got to pay $250 for your $1,000 colonoscopy, my company won't be doing that every Saturday for colonoscopy.
Skip, I have a couple of questions here because we're looking at the Medicaid cuts in Minnesota. I want to give a human story. I was standing in the line in CVS waiting to pick up my prescription, and there was a woman ahead of me, and the pharmacist was almost in tears. She's like, "Ma'am, I've looked at every single coupon. I've tried to get every single thing, but I cannot reduce the price anymore." And she was this slight woman. I could see her from the back, an elderly woman. And she said, "Thank you so much. What is the cost?" And it was over $300. And this woman was just literally standing in front of me shaking. My question is, so here we are looking at throwing out 15,000 people from Medicaid in Minnesota. That's the big thing now, because they're undocumented, even though they're paying into Minnesota Care. Most of them are paying the premiums, etc. My question is, and it frustrates me, that the same groups that are lobbying for that cut not to be made, why are they not offering this solution so that it gets in the news? Why is that not happening so that the legislators and our governor are embarrassed because there is a solution?
And that's been my criticism of the American Medical Association, the American Hospital Association, their counterparts here in Minnesota, even the primary care specialty groups, American Family Physicians, the American Academy of Family Physicians, primary care docs, who are being most burned out by this crazy system. I'm working through P&H, Physicians for National Health Program, to approach single-payer advocates in the national American Academy of Family Physicians, saying, what is wrong with you? Why isn't the academy coming off for single payer? How much longer do you want to see primary care docs and nurses burning out because of the excessive demands of this crazy system? And I don't want to name names, but a lot of the groups that many of us are probably part of, some of the groups that are protecting immigrants against the attacks from ICE, they're not out there telling you what I'm telling you.
Yeah.
We have got to get all of our allies understanding that people like Wickland and other, especially DFLers, they know the system sucks. They know the pain it's causing. We don't need to line them up and say, listen to 5 sob stories. They've heard it, they know it. What they need is help understanding what to do about it. And we're one of the few people delivering that message. So, I mean, I imagine that there would be some people that maybe might watch the videotape of this meeting later and say, gosh, Kip didn't tell many horror stories tonight. I didn't tell many horror stories.
We know them.
Because I think everybody here knows them.
Yeah.
I do think horror stories are useful if maybe we start organizing in Richfield. Because I think it helps break the ice. Everybody gets, we share information. But if we're talking to Wickland, Senator Wickland, we know she knows these horror stories. We don't need to take up valuable time telling her horror stories.
So is it as simple as us looking at their records, because that record is public, to say who's funding you for your election? So when John was saying over here, follow the money, is that what he is referring to? Is that what is causing the hesitation? That because we have privatized elections, is that the issue?
You know, the people in Minnesota legislature, the DFLers, I and others were talking to in the early 90s, it became apparent to us around 1990 and 1991, and I'm just still a little reluctant to name their names.
Yeah, there's no need.
Because they're good people. I agree with them on 98% of every other issue, but they were sold on HMOs. And I met George Halverson. I don't know if anybody ever did, but Halverson was the CEO of Group Health Insurance, had a nice office in St. Paul. Then he became the CEO of Health Partners when they merged with another HMO. Then he went out to Oakland and became the CEO of the biggest HMO in the country, Kaiser. Wonderful man. He gave me rides from the COAC office near Raymond and University
Right.
to some meetings at the Capitol. We had a good conversation. I loved the man. But I know that all these good people, well, Albert is probably an exception. He was making a lot of money eventually. But a lot of the DFL legislators I was talking to, I know they were not making big bucks off of their support for what George Halverson was telling them. It was just that it made sense that we need HMOs because,
What is going on?
yes, that's why I repeat, we need a Halberstam to write the best and the brightest in healthcare. And I'd love to go back to some of those folks now that they've had a chance to see how their handiwork worked out. If Ted Kennedy were alive, I'd like to have a conversation with him. He was a big HMO proponent by the early 70s. Some of the people whose names that I don't want to mention just yet, one of them died a couple years ago. I'd love to go back to him now and say, you've had a long time to watch your little HMO idea metastasize into a toxic, predatory, democracy-destroying industry. What are your thoughts now? I really would like to hear him say it. This is what I was thinking. Because when I talked to him, I got cordially brushed off.
Okay, are there any more questions? Because I do think the quality part of this presentation is very, very important. Are there any other pressing questions? I know I've asked too many. Would you like to take her, anybody want, the bathrooms are right there, just help you, help yourself.